Hi, this is Sofiane El Djouzi. I'm a GI and bariatric surgeon from Chicago, and I have the pleasure of being here today for the SAGES meeting in the beautiful Baltimore. As part of the Trailblazers project with SAGES, I have a terrific guest, an overachieved person. He's a well-known educator. He did the first laparoscopic Nissen fundoplication approximately 30 years ago. So that's a career. This is Professor Bernard Dallemange, who I welcome to SAGES.
Thank you very much. Thank you very much for the invitation.
You're welcome. It's our pleasure. As one known, Professor Dallemange is one of the pioneers in the field of foregut surgery. I personally have learned a lot from his teachings, publications, videos. I've had the chance to travel to Strasbourg in France, not operate with him, but really learn from his pearls and tricks. One of the questions I have for you, Professor, is what was the main trigger for you to land in this field, the field of foregut surgery? How did this happen?
It's a long story because you mentioned that we described that almost 30 years ago. So I was a surgeon before starting with the laparoscopic Nissen. In fact, it's based on my surgical education. I was what we called at that time in Belgium sus-mesocolic surgeon. So I was used to do esophageal, gastric, liver, pancreatic surgery. This was really my field of work in open surgery. Then back in '87, I started to look a little bit at laparoscopy, starting with diagnostic for liver disease, etc. And I met a French guy called Philippe Mouret, who was the first to report the laparoscopic cholecystectomy, and I started to enter the laparoscopic field. But being a foregut surgeon or upper GI surgeon, no matter how you call it, of course, I looked not only on the gallbladder, but also a little bit on the side of the stomach, and having this quite significant experience in open surgery with reflux disease, we thought that it would be interesting to look a little bit around with the laparoscope, because there were obviously significant advantage that we observed for laparoscopic cholecystectomy. We thought, okay, anti-reflux surgery was something quite difficult for the patient at the time, because it was huge surgery, huge incision, a lot of pain, risk of splenectomies, etc. And we start to look a little bit around, and then we move back to the lab, working on animals, trying to establish the basics of Nissen fundoplication on the animals. We did several animals. Then once I had a patient who had a gallbladder disease and reflux, and we discussed with the patient, and I said, okay, I know how to do cholecystectomy, and I know how to do Nissen fundoplication on animals. Would you agree that we just have a look and see if we can do it?
So there was a consent for the first laparoscopic Nissen.
That's right. The patient said, yes, okay, I would like to have both my gallbladder disease and my reflux disease fixed. And we did it. And initially it was not that easy, of course, because the main problem was the instrumentation. You have to keep in mind that at the time, needle holder, laparoscopic needle holder didn't exist. So to do sutures was quite challenging. But finally we did it, and this patient had a beautiful outcome with a lot of studies, radioanalytical studies, just to be sure that we did the right thing. And it works, and it was a starting point of the experience with the fundoplication.
The journey, 30 years journey.
Yeah.
So from what you told me, it sounds like you need a mentor to start, and you had a mentor, or maybe you had mentors.
I had a mentor in open surgery, of course, because I was teach in functional disease of the esophagus, so I know about the physiology. I know about the open surgery. So what we did is to reproduce exactly what we were used to do in open surgery, but using different instruments. And so initially it was quite challenging, but rapidly with the experience of laparoscopy, we make it some sort of quite simple, even if today I still consider the fundoplication as a quite difficult operation, requires a lot of laparoscopic skills, but also a lot of mental skills, because it's a functional disease. So really the main topic is not to hurt the patient. Quality of life is the major issue for this patient. We're not treating cancer, we're treating function. So
Sure.
it's very, very important, and that's why I always say that my surgery is only a little part of all the process of managing people with reflux disease. So it's just a little bit of it.
It sounds like it's the tip of the iceberg. And that really leads me to the second question. I myself am a foregut surgeon.
Mm-hmm.
I had the pleasure visiting your home platform in Strasbourg with the ERCAT, with Maresco and the others. And I must say it's a unique place.
Yes. Indeed.
Everybody would state the same statement. I think you have a magnificent place.
Mm-hmm.
And I must say have everything, but it's not the case everywhere else.
Sure.
If I'm interested and I'm very eager at starting a foregut practice, and I really want to start it well,
Mm-hmm.
what are really the key elements that you would recommend to me to be successful?
Yeah. First, for me, it's really very important is to know the physiology. Again, for bariatric surgery is a little bit different, but even if we're talking about metabolic surgery, it's something that you have to understand before going to surgery, because surgery is just part of it, and functional disease is also the same. Surgery is just part of the spectrum of the disease. So you need to master laparoscopy. So it means that you need training in laparoscopy. We know the problem of NNI coordination, etc., etc. So that's something that everybody is. I'm not a special guy. I've been practicing a lot to get the skills that I have today. So this is part of the surgery. So you have to look at your training. You can do it on ex vivo models. Then progressively you go to in vivo models, and then you can skip to humans.
Mm-hmm.
But this is a very important issue, and you know it in ERCAD. We have a lot of work just teaching practical laparoscopy, basic laparoscopic skills. This is one point. So the second point is to understand the function, and then probably you are ready to go for more, I would say, more complex surgery, because functional surgery is complex surgery. But it's really the pathway that you have to follow to be sure that you are first able to do surgery, laparoscopic surgery, and second, you understand what you're doing, which is very important. And then once you got this, you have to find your way of doing that, and probably is to look at the experience of other people. When I start to think about fundoplication, I have a lot of reference, and my master was Tom de Meester, who is the master in reflux disease. So I'm always based my ideas, my developments on the fundamental principles of Tom de Meester. Even if things have changed, the physiological testings have changed, a lot of things have changed, but you have to always to look at the most important information that you can get from the past, because the idea is not really to reinvent the wheel. So what is my Nissen today is probably sort of the same the exact reproduction of what Tom de Meester described 40 years ago, and we adapt a little bit the technique based on our experience, results, success, failures, and that's probably what creates what we consider today, at least in our hands, probably a good operation. So it's a very long process. So the problem of fundoplication is that people who were a little bit skilled in laparoscopic surgery thought, oh, it's an easy, you have just to wrap the stomach around the esophagus. And if you look at the rise and fall of anti-reflux surgery, it was caused by that. Sure. A lot of people enter that without knowing really the key steps of this operation. We are looking at all the details of the operation. You know it because you've seen it. So that's a long process. Yeah.
And I really appreciate what you going in detail about. And I think if I summarize what you've just said, obviously, one, surgery is like, it's a tip of the iceberg.
That's
it's just
right.
a small portion.
Sure.
Before that, you really need to understand the pathology, how you can diagnose,
That's right.
and you have to have reference points. As you said, you taking Demister as a surgeon who looked into this 4 decades ago.
That's right.
And then you try to modify and see how you could do maybe better or do a little different. So if can you take us through a let's say straightforward laparoscopic Nissen fundoplication with hiatal hernia? I mean, in a nutshell, how would you describe your case?
You mean surgically speaking?
Surgically speaking.
We have a very systematic way of working, and that's what I'm trying to teach all the people who are visiting. I have a young professor that you know, probably Silvana Peretta, who is
Yes.
and really amazing is that when I looking at videos, because I'm editor of WebSearch, so I'm selecting videos, and sometimes I look at the video and I say, who is operating in fact?
That was me. No,
It probably was you, or I can sometimes do not make the difference between myself and Silvana. So it means that I've transmit to Silvana really the key steps, and she's reproducing the key steps because we feel that's probably the best way. So there are very important points is the way you're approaching the mediastinum, the lower mediastinum. Most important tip and factor for a good reflux is all the system, the mechanism has to be totally tension free. We know that in surgery, in bowel surgery, if you have a tension on the system, you will have a leak. You will have some issues with the anastomose. So we have to respect these fundamentals of surgery. Is when we're building another system, we have to do it tension free. So what do we have when we have reflux and hypertonia is the stomach inside of the chest, and we have to bring it back in the abdomen. So the problem is when we bring it back, maybe we have some tension on the esophagus. And if you have tension, the only thing that will happen is everything will move back inside of the chest. So this is the first focus. Let's look at the tension, the axial tension that we have. So one important step of our operation is to do this extensive mediastinal mobilization of the esophagus. That's the basic rule. Number one, go up to the inferior pulmonary vein for all the patients.
To bring the GE junction back into the abdomen.
You have to have this 2 to 3 centimeters tension free.
Of intra-abdominal esophagus.
That's right. So what we have introduced last years is to do systematically, again for teaching purpose, we're doing intraoperative endoscopy. So it's not the judgment of the surgeon who is working either at 8 in the morning or 5 p.m. The evaluation can be totally different.
True.
So we want an endoscopy, and the endoscopy is to check the position of the Z line. And we know that we have a tension-free repair. If we have we have still tension, then we're considering some other alternative like the lengthening procedures, etc.
Sure. Like Colles gastroplasty.
That's right. So this is the first point. Once we get it, the second point is to get this floppy fundus. And I always think to people, we're doing fundoplication. Fundus is not the stomach.
Not the body.
That's right. So we're really focusing on the fundic pouch specifically, not doing an extensive gastric devascularization, but just focusing on the fundus, and we're detaching all the fundus, not only the short gastric or the splenogastric ligament, but
posterior attachments.
taking the back, which is the most important.
Sure.
So that's the second step, and we have a very floppy fundus. Then the third step is to look at the crural repair, because we have to do crural repair in all the patients.
Sure.
Same principle, tension-free. How to do it, and that's the biggest challenge, because if we have small hiatal hernia, it's not a big issue. If we have large hiatal hernia, this is a big issue, and that's where the problems start, because people are coming saying, okay, let's do like inguinal hernia, we put a mesh and it's going to work. Doesn't work. Okay, maybe it reduces the rate of re-herniation,
Recurrence.
but it's not zero. So if it's not zero, means it doesn't work very well.
Sure.
And on the other side, you have risks associated with the prosthetic material around the esophagus. And we've had to deal with a lot of problems, patients having the mesh inside of the esophagus or whatever, you know it. So you have to balance the way you're repairing the crura with the risk of the patient. And so this problem of the crura repair is probably the weak part of fundoplication or anti-reflux surgery or hiatal hernia surgery, is the hiatus. So again, if we're feeling too much tension, we're adding some pledgets. That's the first choice. We're using a lot of times absorbable mesh to protect during the first weeks and months after surgery. And if we have really a big problem, we're using relaxing incision to be able to close the crura around the esophagus and putting a mesh away from the esophagus, so away from the risks. And then the final step is to create a fundo. And it's very interesting because I was with Tom the Minister this morning in one session. And he says, but just look at the fundoplication. They're all doing 4 or 5 centimeters. And again, I said to the guys, I said, let's look back at the work 40 years ago. We have to do very small fundoplication, 1 to 2 centimeters, 2 stitches maximum, to secure this valve on the esophagus or the G junction, because everything is moving together, and it's done. So when you have these little steps in your mind, and you teach people to respect these different steps, we're coming to the situation where I can't see if it's me or my young professor who is doing surgery. It's exactly the same. So it's not because of me. I think it's something that can be done by a lot of people if they are properly taught.
I'm fascinated by what you just said, because it feels like you're doing the surgery exactly the way I'm doing it. So I'm very happy.
Thank you very much.
Let's just go back to a couple of crucial points I think I would like to know about, and a lot of people who are interested in this field would like to hear from you. I think you touched on intra-abdominal esophagus, so we have a consensus that you need, some people would say 3, 2.5, but you need a certain length,
Sure.
Let's call it 2 to 3 centimeters of esophagus inside the abdomen that's not under tension,
That's
do not have a
right.
recurrence. When you close your crura, I like the fact that you went stepwise. So I use sutures, I pledge them, I make sure I'm closing, there's no tension. And then you mentioned that you use absorbable meshes. Are they, what type of meshes? Are they the biologic or?
I tried the biologic, but
meshes.
we know from works, randomized trials done in the United States, that it doesn't stay. So it's very costly. So I moved to the most cheap mesh, which is Vicryl. The Vicryl mesh that we used to use in open surgery to protect the abdomen when we did open surgery, you remember. And Vicryl is very cheap. So I'm using Vicryl mesh.
So that's your to-go mesh this time.
Yeah. And as I was mentioning, in very rare situations where really I cannot approximate the muscles, then we're doing relaxing incision. And when I do the relaxing incision, I'm covering my diaphragmatic hernia with a simple prosthetic mesh. So again,
Cortex or any?
well, I'm using polypropylene.
Okay. And then when you do the relaxing, because I know I was trained in doing it on the right. I'm always afraid of doing it on the left because of the phrenic nerve.
Sure.
So on the right, I go next to the cruise and I avoid the IVC. I try to find that way. I've seen some surgeons who dare to be very close to the IVC. I would not do that. But what's your take, right, left, and how do you do it?
First choice would be the right, because it's probably less risky, at least for the nerves, not for the vena cava. So again, you know, as I do, that the anatomy is varying between people. You have people who have the vena cava very close to the crus. And then, of course, you don't want to tease the vena cava, so you will move on the left side. But I would say that my first choice is on the right side, because it's probably the easiest way, because you have a perfect view first. You can be sure that you cut all the musculature, So you have really this relaxing effect, and you can see it. It's obvious. The hole is growing as soon as you're stitching, so you know that you've done something that is some significance.
Sure.
When I have problems, and sometimes it happens in redos or trido surgery, when you have some obscure anatomy on the vena cava on the right side, etc., or very short distance, then I'm moving to the left, knowing the problem of the diaphragmatic nerves. So I try to be not too far away from the left cruise, and not too long, because we know that if we're approaching too medial to the diaphragm, that's where we get the left diaphragmatic nerve. So you have to stay a little bit posterior. It's a little bit more tricky because you have always this gastrosplenic ligament who's coming, so to get the exposure is a little bit more tricky.
Challenging.
So probably the right side is the best option at first. Yeah.
But then how about the you mentioned that the fundoplication should be floppy.
What?
How do you measure that? Is it through a bougie? You said you scope in every case?
Yeah. For the fundoplication, it's visual, because when you do a good fundic mobilization, you can do whatever you want. I can introduce a 70 French bougie if I want, because I'm looking and you see that there is no tension. And one sign is that when you pass the fundus behind the esophagus, you go to drink your coffee, you're coming back, the valve is still in the position on the right side of the esophagus, means there is no tension. And this is a good criteria to know that you have done a good fundic mobilization. If the valve is away back to the spleen, you know that there is a problem, and you have to verify what you've done. So my advice, you put the stomach in position, you go and drink your coffee, you're coming back, the valve is still there, you know that you want to do a fundoplication. Then the next bougie or not. I've used bougie in the past, but really for the first 20 cases. Then I quit because I could see that I was doing it floppy. Then to validate that, we made a study using the endoflip,
Yes.
this impedance planimetry. And very interestingly, we did a comparative trial between centers in England, in the United States, and in Europe, in our center. And we were producing the same valve. And the guys who were doing the valve were the guys who were doing exactly the same valve as we do. Same fundic mobilization, same length of the valve. And using these objective testings, we have all corresponding results. So we did it with Blair Job in Pittsburgh. We did in England, in France, same results. So
Great.
that's where we thought, okay, having this objective data in the mind and this vision of a valve when we're constructing it, we thought, okay, we don't need it systematically. We use it when we are dealing with redos for dysphagia, etc., to localize exactly the problems. We're still using the endoflip a lot of time. So this is something that is provides significant information when you are in trouble. You don't know if you do it too much or not too much, or you have dysphagia, you don't know. This is objective data.
From your extensive experience, over 30 years at least in the field of foregut surgery, what are the do's and the don'ts from when it comes to complex revisional foregut surgery? What are the things that you advise for, and things that we should just draw a red line?
I think that patient assessment is very important, is to understand the problem of the patient. That's really the first thing. My second consideration is where does the patient have the first surgery? If it's coming from a guy with a huge experience and good results and have got problems, you know that you are entering some difficult situation, and then you have to come with all your devices to understand what happens. And I mentioned the endoflip, etc.
Yes.
If it's coming from a guy who is doing one Nissen each 5 years, you know starting that there's is a technical mistake. So there you're going rapidly in the patients because you find twist valve, you find, I have a list of all the mistakes that are very systematic. So this is the first point. Second point is how many surgeries have had few patients. Is first recurrence, second recurrence, third recurrence. So today we understand that, again, based on the selection, symptoms, history, surgical history of the patient, where he's coming from, we can consider 3-do, for example. This is something that we can do. But if it's patients having had a good surgery systematically, first, second, and third, then you have to go to another way. It doesn't make sense to redo a fundoplication.
Sure.
You're not more intelligent than the previous good surgeons. So you have to change your mind. And what we are used to do is to discuss the patient about what we're calling gastric disconnection is in fact a sort of a bypass technique, coming with a Roux-en-Y on the esophagus and excluding totally the stomach. It works very well for these very complex patients. Yeah. So really the idea is not pretending that you are more intelligent than the previous guys, and to redo something that fails systematically doesn't make sense. So you have to find another way. Yeah.
Excellent. Any let's say last minute pearls for let's say for me personally, if I want to be very successful in this field?
You have to be very critical with yourself, and that's what I did all my life. It's always to look at my data, my results, the patients, spending time with the patients, listening to the patient. One thing that I've understood is that when a patient is coming to you after your surgery or surgery done by another one with complaints that didn't exist before and occur after surgery, you have to really open your mind, and you hearing the patient, discussing a lot with the patient, because I've got a lot of patients who were considered as being crazy,
yes,
describing side effects after fundo, etc., and reject by the previous surgeons or gastroenterologists, saying, okay, this patient is totally crazy. That's not true. That's not true. If a patient has complained that never mentioned before surgery, there's something in surgery, and then you have to be very, very cautious, discussing with the patient and saying, okay, I can check what happens at your first surgery, and 95% of the case you will find the problem. So there is no crazy patients. This is the message that I've listened during all this career, and in all these crazy patients I could find something.
So be humble and criticize yourself.
Yeah, all the time.
Really appreciate your time, Professor.
Thank you.
It's been a pleasure.
Merci beaucoup. Merci beaucoup.
It's been a pleasure. Thank you.
Merci.
Once again, this was for the Trailblazers for the Foregut Surgery here, SAGES 2019 in Baltimore.